Okay, everyone. My name's Mark Holland. I'm a consultant working at Salford Royal Hospital in acute medicine, and I'm also a visiting professor at University of Bolton. And this lecture is on the topic of sepsis. It's very much at beginner level, but hopefully it will be useful for most people. And at the end, I've got my email address, and if there's any questions, you can contact me afterwards. There's a PowerPoint presentation that goes with this talk, and probably it'd be best to access the PowerPoint so that you can look at both things at the same time and follow the slides. Okay, so the aims and objectives are to develop an increased understanding of sepsis, and the specific objectives are to learn how common sepsis is, understand how awareness of sepsis can save lives, understand how we define sepsis, appreciate the importance of physiology and measuring physiology in people, and specifically something called the National Early Warning Score 2, or the NEWS 2 score, identifying high-risk patients for sepsis, knowing the basics of the care that needs to be initiated outside of a critical care setting, and to be aware of some of the controversies surrounding sepsis. This talk and the presentation that I've got ready for you are very much an introduction to the subject, but hopefully it will whet your appetite. On the PowerPoint, I've provided lots of references so that you can look for more information online, and I'd highly recommend that you do that. So the size of the problem on slide number 4 is there's a useful link to the UK Sepsis Trust website, and they give some useful figures. They argue that there's about 200,000 cases of sepsis per year in the UK, with 52,000 people dying, and that sepsis kills more people in the UK every year than the deaths from breast, bowel and prostate cancer combined. So it's a big problem, a big problem. And this has been identified previously in a number of areas, none more so than this report, which is called Just Say Sepsis. And it's published by a group of people called NCPOD, which is the National Confidential Inquiry into Patient Outcomes and Deaths. And they publish a few reports every year. And their methodology is that they take the case notes of patients with a specific condition, usually where there's been a bad outcome, such as death, and they'll look back to see what the quality of care was. These reports are extremely useful and they highlight deficiencies in care, but it must be said that there are some weaknesses in these reports. By looking back retrospectively, a lot of their analysis is based on the fact that items are not documented in notes, which doesn't necessarily mean that that aspect of care didn't take place, although of course we are no more than the records that we write. However, the report itself came out with some very useful recommendations, and by chance, back in 2015, I was then the president of the Society for Acute Medicine, and I was asked to attend this meeting and give our society's response to Just Say Sepsis. And again, I seem to remember thinking at the time that there were lots of useful points that were made, but one of the points that came from someone in the audience was that a lot of these people were suspected to have sepsis, but never actually had a proven infection. And that goes back to one of the earlier slides, the estimate of the number of cases in the UK every year by the UK Sepsis Trust, whether people truly actually had infections or not. Moving on to my next slide, number 6. What is sepsis? It's not always clear. I'll give you a very simple but very unofficial view. I stress the word unofficial. I'd consider sepsis as a severe infection which makes a patient physiologically unstable. And even if such patients are not septic, by definition, if someone's unstable with an infection, there's a good chance that they could deteriorate if you don't intervene. So it's not just about treating people with established sepsis, it's actually about identifying people at risk of deteriorating. And actually, the audience that's watching this video who undertake clinical practice, assuming that you don't work in a critical care setting, you'll be finding this is much more useful for helping you to identify people that you see in your clinical work. And sepsis is just as much about the community as it is about hospitals. As that last slide said, 70% of cases of sepsis originated in the community in the NCPOD study. So up until February 2016, sepsis was based on these physiological criteria, which were called the SIRS criteria. And you had to have 2 of them to be SIRS positive. And if you had SIRS positive criteria, 2 out of the 6 now, in the past there have been fewer, but there are 6 at the moment. If you had 2 SIRS criteria and an infection, you were said to have sepsis. If you had sepsis and an organ in your body that wasn't working properly, commonly the kidney is what I see in my practice, people with acute kidney injury, then you had severe sepsis. And if you had severe sepsis and hypotension, a low blood pressure, especially a low blood pressure that didn't respond to fluids, you had septic shock. And this was how sepsis was defined. But as you can see, if you had an infection and you had a temperature, which is part of an infection, as you know, and you had a fast heart rate, which often goes along with an infection, or raised white blood cells, it's very easy to get 2 positive SIRS criteria. If you have pneumonia, the chances are your respiratory rate will be above 20, you will have a temperature. So to have 2 SIRS criteria is very easy, and therefore lots and lots of people could technically be defined as having sepsis. These are the common infections. Pneumonia is at the top of the list, and as you go down the list, you've got other infections. Some of them are very, very serious. Infection in your joints called septic arthritis is a genuine medical emergency. But then in February 2016, the definition of sepsis was adapted, it was changed. And sepsis now had a much more specific definition as life-threatening organ dysfunction caused by a dysregulated host response to infection, which basically means that if you had an infection, you responded in such a way that it made you physiologically unstable. And this could be measured by a score called SOFA, Sequential Sepsis Related Organ Failure Assessment. But in essence, this assessment could only really be measured in a critical care setting. And if you saw before, you could almost diagnose sepsis once upon a time in a GP practice because, you know, you had a temperature and you had a tachycardia and an infection. So you had pneumonia and GP could say, oh, you got sepsis, you can go to hospital. Whereas now you can see that to achieve the sepsis threshold became slightly more difficult. So there were still people out there with really nasty infections, but they weren't being classed as sepsis because the definition changed. But the patients didn't change, which is the important thing. Of course they didn't. So it's still really important that people who have got SIRS criteria, that we maybe don't give them the label of sepsis, but they're at high risk of deterioration if we don't do anything. So although the definition has changed, the patients haven't changed. So please remember that point. Septic shock now had a much clearer and well-defined definition. And in septic shock, you needed drugs called vasopressors, which basically means drugs that raise your blood pressure, noradrenaline, and that would occur in an ITU setting. For those of us outside of the ITU setting who can't measure SOFA, we were given something called Q-SOFA or quick SOFA. And this is a very abbreviated form of SOFA, and it enables us to look at some physiological parameters, and it can then tell us whether somebody may or may not be at risk of deteriorating with a high mortality and a high predicted chance of going to the intensive care or the critical care area. And that's slide 10 on my presentation. And moving on to slide 11, we talk a bit more about Q-SOFA. It's described as a bedside prompt to identify patients whose risk of outcome is poor. So it's not a definition of sepsis. And people get confused here because people come to hospital nowadays and people say, oh, they're Q-SOFA positive, they got sepsis. Well, they haven't got sepsis because sepsis was the definition, the new definition is above. Q-SOFA tells us that patients may well develop sepsis, and therefore we have to intervene and do something so that we don't reach the point of full-blown sepsis. So it's not a definition of sepsis, it's a tool for those of us not working in critical areas to identify who may develop sepsis. And there are 3 criteria to Q-SOFA: respiratory rate, altered mentation or altered mental state. And it's important that we state the word altered because lots of people, especially older patients who may have dementia, for example, can already have an altered mental state, which is chronic. So it's a new mental state. So that includes everyone who may have sepsis and a low blood pressure. And if you've got 2 or more, you're Q-SOFA positive. If you're Q-SOFA positive, I stress the point, doesn't mean you've got sepsis. It means you're at high risk of progressing to sepsis and progressing to a poor outcome. And as slide number 12 says, it's useful out of hospital. It can be used in primary care. It can be used in the emergency department, in hospital wards. So what's it mean to have 2 definitions? Why does it make a difference? Because what you can see here is yellow area, which tells us about everyone who comes to hospital and their physiology. And Q-SOFA and SIRS make up those yellow areas. And blue are the people who come to hospital with an infection. And those blue circles have remained the same size. And the red areas are people who have got sepsis. Now, so what you can see that when we define sepsis using SIRS criteria, the red circle is much bigger than when we've moved over to Q-SOFA. Of course, I said Q-SOFA isn't a definition of sepsis, but if we consider that Q-SOFA is going to highlight a group of people who may progress to sepsis, it's going to make that red circle a lot smaller. And there are pros and cons to this argument. The pro to this argument means that we won't be unnecessarily diagnosing sepsis in people who haven't actually got sepsis. They might be physiologically unstable for another reason that we need to look for. We won't overuse antibiotics, which are a precious resource. However, if we use SIRS criteria, the chance that we'll ever miss anyone with sepsis is very, very remote. However, we will label a lot of people as having sepsis who haven't got sepsis. And that's borne out by the next slide, number 14. SIRS has a very high sensitivity. It picks everyone up who's got sepsis. However, a lot of the people that it picks up actually haven't got sepsis. So it's got a poor specificity. Q-SOFA has a much better specificity. If you're positive for Q-SOFA, the chances are that if it says that you're going to deteriorate, the chances are you will deteriorate. However, it fails to pick up a lot of people who don't deteriorate. So we can use the news score instead. And it's what we can see with the news score is that different values of news score, the sensitivities are higher than they might be with Q-SOFA. And the specificities are about the same or perhaps a little bit lower. So news score is another good way of looking at physiological stability. Again, it doesn't define sepsis, but it tells us that if people have got an infection and a high news score, the chances are higher that they will need admission to a critical care, intensive care unit, or that they might die. So that's what these scores are. And it's really important with these scores that we don't use them purely as definitions. We use them as a way of assessing physiological stability, and we use them as a guideline for the fact that people may deteriorate. And it's really important that we are aware that people could deteriorate, and to identify people who could deteriorate, as NCPOD suggested that we do. However, in a lot of these people, we still need to keep an open mind that a lot of them won't deteriorate because we will intervene early and make positive measures. So for those of you who are not familiar with news, and I hope everyone is, these are the criteria down the left side, and across the top you've got the scores. So let's just take an example here on slide 15. We've got a patient who's got a very high temperature, and as you see, a temperature up to 39 doesn't give you that much. So let's say that this person's scores 1 point for that. And then they've got a very high respiratory rate of over 25. So now they've got a score of 4. We'll see in a minute on the next table that a score of 4 doesn't necessarily put you into a high risk group, but having a score of 3 by itself in one category does. And respiratory rate is known to be one of those markers of physiology that is very good at predicting poor outcome. And slide 16 shows the different levels of news and the risk to the patient of a poor outcome. News doesn't just apply to sepsis, of course. News isn't sepsis specific. We can use news in patients with any particular condition. So, for example, if I've got a patient who's got a low blood pressure because, for example, they've got something like a stoma with high output of fluid, or I might have a patient who's on drugs that lower the blood pressure and they've come in with heart failure. They could have a high news score, have no signs of infection at all. So news isn't specific at all to infections, but the higher your news, the worse your outcome. That's a very consistent message. And the early warning score shouldn't just be taken at one score at a time in place. The news score is about measuring the score when someone first arrives at hospital or even in the community, and then seeing how the score changes over time. And quite interestingly, many people who come to hospital with a normal news score subsequently deteriorate. And remember that in people, we're just going off the beaten track a bit here, but for people who are having something like a heart attack, they often have a very normal news score. However, they're still at high risk of death. So news doesn't always tell us the people who are going to die. But news changing and going higher is a worrying sign, and people with a very high news score on its own is a worrying sign. So please know about the news. And again, I've put the link. So who's at risk of getting sepsis? Well, I've used NICE's criteria here because it also gives me an excuse on slide 17 to put in the link to NICE, a very important document, of course. So age, very young, very old, or frail people. Remember, frailty is more common in older people, but not all old people are frail. And then people who have got problems with their immune system. And the common thing that I see in practice for the immune system is, of course, diabetes and steroid therapy. So in general medical practice, in acute medicine, they're the big worries for me. But there's other ones on there. Chemotherapy for cancer, that's an obvious one. Everyone would know that. Immune suppressant drugs, which are used for other conditions, such as rheumatoid arthritis. Crohn's disease, they use these potent drugs as well, of course. Nowadays, lots of inflammatory conditions need these things. Having had recent surgery could be a problem, especially bowel surgery. Anything that breaches the skin. Intravenous drug misuse, seeing abscesses in the groin, endocarditis, which was on the list earlier, is a condition that we see in people who users of intravenous drugs, and people who've got bits of material in their body that shouldn't be there. For example, lines that we use to give people drugs. Urinary catheters are extremely dangerous. Risk of what's called gram-negative sepsis, a very potent class of bugs, the gram-negative bugs. People who've got prosthetic valves that can become infected. And on there, of course, you've also got the spleen. So not many people are aware, but if your spleen has been removed, you're at high risk of getting infections. And you don't even need to have your spleen removed. There are certain disease processes that stop your spleen from working as well. One of them is sickle cell disease, and another one is, interestingly, celiac disease. So there are certain conditions that stop your spleen from working as well as it should. If your spleen doesn't work as well as it should, you're at risk of certain infections. One of them is called pneumococcus, the germ that causes the common pneumococcal pneumonia, but also causes meningitis. Other high-risk patients are those who are pregnant, and there's a list on slide 18 of other things that go along with pregnancy. And then, of course, the very young neonates on slide 19, again summarised from NICE. So we've got to stop for a second here and think about sepsis, because nobody is going to come to you, obviously, with sepsis every single time. Sometimes it will be obvious that they've got sepsis. The person with pneumonia, who's got a high temperature, who's got a low blood pressure, who's tachycardic, who's got low oxygen saturations. And while we're talking about low oxygen saturations, they're cheap as chips. You can buy yourself an oxygen oximeter over the internet for only a very few number of pounds. You put it on the end of someone's finger and it tells you their oxygen saturation. It's quite a useful tool. Anyway, I digress. Apologies for that. But we need to think that when we're talking about sepsis, we can't just diagnose sepsis because someone's got a type of infection, because not everyone with pneumonia has got sepsis. We can't diagnose it just with SIRS criteria, because as we've already seen, you can have SIRS criteria positive for lots of reasons and not have sepsis. We've got to realise that the news score on its own can't tell us that someone's got sepsis. So we have to triangulate all of this information. We have to take our patient, look at how well that patient is, look at their skin, is it mottled? Do they feel unwell? That's a very important sign. Patients who tell you that they feel unwell are unwell. That's scientifically proven. And then we have to look at their physiology parameters, their news score, their SIRS criteria, perhaps, their Q-SOFA to predict what's going on. And we triangulate the patient, we triangulate the type of infection they've got, we triangulate their physiological stability. And then we decide, have they got sepsis or haven't they got sepsis? And even if they've not got sepsis, we still know now, or hopefully you appreciate, that people with infections who are unwell could be teetering on the edge of sepsis, and we still need to intervene in those people. So there's no one single magic way of diagnosing sepsis. It's triangulation. The patient, the physiology, and the infection. Some patients, as we've already said, are very high risk of this type of problem. And there are red flag criteria that can tell us that someone is developing bad sepsis or is on the verge, is imminently going to develop bad sepsis. And these are the red flags that I've listed in slide number 20. And by red flags, we mean people with a very low blood pressure. But blood pressure is also relative. So for anyone who's very young and slim watching this video, the chances are you've probably got a very low blood pressure most of the time. However, as you get older, like myself, your blood pressure naturally goes up. But for people who are hypertensive, who might have a blood pressure on a day-to-day basis of 160, going down to 110 systolic might mean that they stop perfusing their kidneys, whereas somebody who's younger can probably perfuse their kidneys at a much lower blood pressure. So you need to be aware again of the patient. The patient is important, patient-specific criteria. And the drugs that they're on also make a huge difference. Drugs that drop your blood pressure and stop you perfusing your kidneys are more likely that you will then get a complication in your kidney. A drug like the ACE inhibitors, for example, if you've got acute kidney injury. Although you shouldn't be stopping ACE inhibitors necessarily in people who've got heart failure. So you can see it's very difficult, very complex dealing with these people, because these are quite often people who develop sepsis are not well people. Although you'll read articles in the newspapers about someone who'd been fit and well all of their life, relatively young, and suddenly got this overwhelming infection and very sadly passed away. That isn't typical of these 200,000 sepsis cases. Most of these sepsis cases are people who have got chronic diseases or a high risk, such as older people with diabetes, on steroids, etc., etc. So we then need to know how to care for these people now that we can identify them. Okay. Now that we can be like a clever detective piecing together all of these bits of information, we've identified that this person is at high risk, so we want to do something. Now, the bundle of care for sepsis is called the Sepsis 6, and over time it's changed. I won't go back over the historical types of Sepsis 6, but currently it says that in hospital somebody should be seen by a senior clinician, by what we call ST3, that's a medical registrar or above, or a nurse equivalent. So the students on my courses, which is advanced care practice, they're training to be advanced care practitioners, and they would be more than capable of being the first responder to see someone with sepsis. Oxygen should be administered if the patient's oxygen saturations are low, but remembering that people who've got chronic obstructive pulmonary disease, COPD, often run low oxygen levels. And of course, if you give them too much oxygen or any oxygen at all, sometimes it can precipitate respiratory failure. So you have to be careful in people who have got chronic low oxygen saturations, which is why it's always worth knowing your population of patients. I've always argued that most people should actually have a physiology passport so that we know what someone's physiology is when they're well, because then we can compare it to when they're unwell. So I've already made examples that actually, you know, your physiology can be specific to you. And it's not all based on what's normal. What's normal for one person can be different for someone else. We need to get IV access into these people and take blood tests. And the important blood test is what's called a blood culture, because the blood culture is the one where we might grow the bug. And if we grow the bug, we'll know what we're dealing with, and we'll also know which is the best antibiotic to use. We need to give intravenous antibiotics in these cases, or maybe other intravenous drugs if it's a different type of infection, such as a fungus. We need to give intravenous fluids, especially if the blood pressure is low. And we need to monitor the patient, and that's what we got the News 2 for. We can also measure urine output. Sometimes we have to put a catheter into people, but I try to avoid catheters if I possibly can, unless someone's extremely ill. And we can measure their lactate, a chemical in the bloodstream that tells us how their metabolism is faring. And if the lactate is rising, that can be very worrying as well. What's not on that list is that if you are worried, and if the person is an appropriate candidate, a conversation should take place very, very quickly with critical care colleagues to at least be aware of the patient, because they might not need to go to critical care now, but they might need to go in 6 hours. And consequently, you want them to be on critical care's radar so that they know that that patient is in the building, in the hospital. Likewise, in general practice, if they're sending a patient in who's physiologically unstable to the emergency department or to acute medicine, it's good for us to know that that person's coming early. Conversations and communication are key in sepsis, as they are in every other single walk of life. So I did say that there are some controversies, and I won't go over the details, albeit to say that I've been to lectures where people who support the SIRS model and wish to diagnose as many people as possible with sepsis have given their opinion very strongly. And people who feel that sepsis should actually be reserved for people who go to the intensive care, or people who we feel have got sepsis on a ward but wouldn't benefit from sepsis care, that definition needs to be reversed. And other people have basically just got very nasty infections that need aggressive treatment. Doesn't mean that they don't need the treatment. It doesn't mean that we underplay what's going on. It just means the definition isn't sepsis. And these groups argue quite aggressively for their different stances on this issue. I think the key, though, is to be aware that sepsis is a dangerous condition. And go back to my point before. Think of the patient. Is that patient at risk from their infection? Are they more at risk of somebody who hasn't got significant comorbidities? Are they currently physiologically unstable? What is the type of infection that they've got? Is that an infection that could destabilize them? But as I say, the field of sepsis can be quite controversial, but then everything is in medicine. So we've got a little summary now, because I'm sure you've listened to me enough. We're on to slide number 23. So sepsis is an evolving field, again, like anything in medicine. And even in most recent past, the definition of a condition that we all know about changed fundamentally. All healthcare professionals, wherever you work, will see patients with sepsis or an infection that can progress to sepsis, which is probably more important for most people listening or watching this video. It's a matter of, could it progress? Okay. And healthcare professionals must know common infections that lead to sepsis, who is at high risk of sepsis, and how to identify physiological instability. And I've given you the tools to do all of those things. And to know that you have to start treatment early. You mustn't just give treatment blindly. Lots of elderly people, older people do have heart failure. You have to be careful when you give them lots of intravenous fluid because you can flood their lungs. As I already said, people with COPD often have low oxygen saturations. So sometimes if they've got a very bad infection, we have to give them oxygen. But if we give them the oxygen, it's actually paradoxically poisonous to them. So we have to support their breathing with non-invasive ventilation. So a lot of these steps in management are possibly beyond the scope of many of us. For example, I personally don't administer non-invasive ventilation. But I know when it's needed, and I know who can deliver it, and I know how to identify who needs it. And identifying is just as important as actually being able to do it. So that's the end of this little journey through sepsis. This really is just the tip of the iceberg, but there are some useful references in there. I think it's given a good update on what's going on. Remember the model of triangulation. And that's the end. And that's slide, last slide. And on the last slide, as I said at the beginning, you've got my email. Anyone who's got any questions, happy to answer your emails. Okay, hope you've enjoyed it. And as I say to everyone at the moment, we're living in very difficult times. So stay safe and take care of yourselves. Okay, bye-bye for now.